salary for a family doctor, 158. Now both of those sound pretty good for me. I work in a nonprofit setting, so that's that's a pretty good salary. But when you're facing loans and you're facing the peer pressure of what you go into as a healthcare field, this number and these other numbers are pretty strong draws. But the one thing I challenge you guys is that if you're thinking about, you're in medical school, you're in the medical field and thinking about residency, if you want to really make a difference, then going into primary care is where it's going to be at. That's where the focus of all the money, all the research, all the investment is going to be in primary care. And I think we're going to also see these salaries coming down because there's not going to be as much investment and as much interest in some of the specialties as there has been. There's going to be a change in the way the healthcare career structure works because, I mean, we can even see it in Utah right now. Federal government's putting millions of dollars into creating more community health centers across the state. Who are they hiring? They're hiring PAs, nurse practitioners, pediatricians, and family doctors. That's who they're hiring. So that's where the emphasis is going to be. There's still going to be the need, but I think it's not going to be as sort of lucrative as it has been. So thanks. I think we can go forward right here. And these are the federally qualified health centers that I mentioned. In Utah, I forget how many we have. I think we have about 16. But we've got 6 new ones coming in over the next 6 months. And these are centers that serve the underserved. They offer a sliding scale fee system, which means depending on how much you make is how much you pay. They accept people who are documented and undocumented. Your immigration status doesn't matter. And they provide comprehensive care. They do deliveries, maternity care, kids, senior care. They do it all. And they have a pretty good connection to the best evidence-based medicine. I'm a little biased because my wife used to be a provider here at the one in Taylorsville, but they're pretty good healthcare systems. So if you're interested in going into primary care, but you're worried about your student loans, and you're worried about how am I going to pay off all this debt that I've accrued, if you work for an FQHC, you can actually get some pretty good loan, what is it called, where they just stop worrying about your loans. They pay it off for you. Forgiveness, thanks. Loan forgiveness. It depends on where you practice, but you can get loan forgiveness if you go work for an FQHC, depending on different areas of Utah that you're in. There's some places that forgive it all, others forgive 75, 50, 25%, depending on the area. But definitely check out the FQHCs. They're something unique that not a lot of people know about, and they're a very interesting alternative to private practice. I know a lot of physicians who have gone to private practice, worked in an FQHC, gone back to private practice, and then can't wait to get back to the FQHC because they've seen it on both sides and they realize that this is the place that they want to deliver medicine. The other thing is your malpractice is taken care of if you work there. You don't have to pay any malpractice because the government assumes that liability for you. Jump ahead. Now, as someone who works in the healthcare field, no matter what you are, I mean, we have doctors and nurses listed up here, but you really can be anywhere in the healthcare field, and you have people coming up to you and asking you questions. What is Obamacare? When do I sign up? I've got this thing on my back. Can you take a look at it? You guys probably get all those kinds of questions. And that's because doctors and nurses and people in the healthcare field are some of the most respected people in our community, much more so than politicians, lawyers, or anybody else, and especially for information about healthcare reform. Which is kind of ironic because in medical school or any kind of healthcare field, you're probably not learning about what's in Obamacare. You're learning about, body systems and pedagogy and things like that. But you still get those questions. And so that's one reason why I'm glad to be here to talk to you, because people do trust you if you're in the healthcare field. The challenge is people trust you. If you go to the next slide, please. Unfortunately, they get most of their information from somewhere else. They get it from the news media. If you look at the bottom there, 81% of the information about healthcare reform comes from the news media. Not as much comes from the people that they trust the most. So that's a disparity that we've got that we really need to overcome. And so the way I want to finish this section, I think it's on the next slide, is just give you a quick little primer about the 5 things I'd appreciate if you could mention to folks when they ask you about healthcare reform. First of all, letting them know about healthcare.gov. It still is the preferred portal here in Utah to go and shop for insurance and get your questions answered. So healthcare.gov is not doing well, certainly at the beginning, but it is getting better, and it is going to get to be the place that you're going to go and buy that healthcare insurance. Second, for people who've had problems with buying health insurance, they've struggled with it, they've been denied, they've gotten quotes for premiums that are just astronomical, they can never pay. There's a new system in town. Being sick doesn't matter anymore in terms of what you're paying for your insurance. So it's worth going back and taking a second look and seeing if this is something that can now work for you. The third is, this is probably the most overlooked, is that Obamacare insurance is private insurance. Most people would think it's some sort of government system where, President Obama comes and, checks on you or something like that. No, it's private insurance. It's the same private insurance companies that you see the billboards for driving up and down I-15. And there's 5 of them here in Weber County offering 90 plans on the marketplace. So reminding people that Obamacare is private insurance, and that's what you're buying, and that's the kind of care that you're going to get. Fourth is that there's subsidies out there, as we saw from those 3 families, those 3 examples, that are going to make insurance more affordable. If you struggled with paying for it or never could work it into your budget, the subsidies are there for people who earn between 100 and 400% of poverty, which is a pretty big spectrum of our country here, to make those monthly premiums definitely fit within budget. So again, something to look at. If you don't buy your insurance through the marketplace, you're also leaving that money on the table as well, because it's there and it's available, but if you don't go through the marketplace, you can't access those subsidies. And fifth, and actually I haven't gotten to this, it's in the next section, there are people trained to sign you up, navigators and enrollment specialists that are there that, as someone who works in the healthcare field, you want to make people better. You want to make, help them in whichever way they came to you to get help for. But you're not there to train them and tell them how to sign up for insurance. There are people in our state who are trained to do that. And if you can direct them to those folks, then they can get the help they need, and it's actually more efficient for you. So we could skip forward actually to this section, and let's just skip forward 1 or 2 more slides. This is actually one back there. This is the website that we really want you to send people to, or even go to yourself. TakeCareUtah.org. We set it up in the state for about $1,000. Took us about 3 days to put it together. And what it does is it helps you find those enrollment assisters, those navigators or certified application counselors who are closest to you. It's like finding your nearest Home Depot. You type in your zip code, and then it puts out a Google map and the address and the information for these trained people who can help you. And these people have gone through federal training. They've gotten the same background check you need for a concealed carry permit here in Utah. They passed ethics laws, and they actually carry insurance as well. So if they make mistakes, there's insurance that they carry that can reimburse you if it's something that they do. So it's a pretty serious training procedure. These are not Joe Schmoes off the street. We're going to sit down there and sign you up for insurance. These are trained navigators and certified application counselors that you can access through this website, verified and certified by the state of Utah. So this is a good website to keep in terms of referring people. There's another one which is dialing 211, which is a statewide information number set up by United Way, United Way 211. So if you don't have internet access, you can call 211 on your phone and be connected to the same resources you can get at TakeCareUtah.org. They even have navigators on the phone to answer questions there as well. The third one, you can jump ahead, is the community health systems themselves. Here in Weber County, we have the Midtown Community Health Clinics, and they're a really impressive set of community health clinics in northern Utah. And you can find them by going to ouch.org, which I think is the best acronym in any healthcare nonprofit I found. They're the umbrella organization for all the community health clinics. And not only do they have people there who can make you better and deliver your baby and stuff like that, but they have certified application counselors on staff to sign people up for insurance as well at the same time. One more that I want to mention are insurance brokers. We don't want to leave the broker community out of this. They are interested in this business as well. They've been trained and certified, many of them, to provide the same kind of insurance as well. So if you already have a trusted relationship with a broker, you can see them and they can sign you up for the same coverage, and they're not compensated. You don't have to pay them any money or anything like that. This is what they do, signing people up for insurance. You can find your agents at utah.gov/agent search as well. And then one more, I think. Well, actually, no, that's it. Next is the Medicaid expansion discussion, but I wanted to check on time because I know we might have some questions here that I might want to address as well. Should we go directly to questions, Adam?
You're good. Either way.
What time is it right now? 2:53. Let's do some questions before we jump into Medicaid expansion, because I realize I've spoken for a long time, and maybe you guys had some questions. Got one right there. Yep.
I have 2 questions actually. One is
sure.
It can't be priced out. Is there caps on policies? So when you say an individual can't be priced out, is it regulated cap?
Mm-hmm.
Okay.
Yeah, let me answer that first one. So priced out, what that refers to is if you have diabetes or you have some sort of a health condition, it used to be that an insurance company could say, yes, we'll give you insurance, but it's going to cost you $1,200 a month. And so that's really what's being priced out. It's an offer, but it's not an offer that most people can pay. So in terms of the new marketplace, the price of the insurance you pay isn't going to be adjusted based on your health history, but it will be by your smoking, geography, or your age. And so it is conceivable, though, that if you're 64 years old and you smoke and you live in one of the high-cost geographies, you could be paying quite a bit for that insurance. It could be $700, $800 a month. And if you don't fall into the premium subsidy range, then you would have to pay that full amount. So yeah, no, that could be, some people consider that being priced out. But, you know, for a family of two to not be eligible for premium subsidy, they have to make over $64,000 a year. So you could also argue if you make $64,000 a year, you could afford a $700 a month insurance premium. But it's all relative, and it's all based on perspective. So,
My second question has to do with when the subsidies are distributed. Does it come in the end of your tax credit, or is it done monthly?
Great question. So it's how are the subsidies distributed? And as I mentioned, most people are going to do it one way, but there is a second way you can do as well. Most people are going to get the subsidy check is going to be sent to their insurance company every month along with the check that they write as well. And those two checks are going to meet and make up their premium. If you could pay your full premium, you could do that every month and then get your subsidy as a tax kind of refund or a tax credit at the end of the year when you file your taxes for the next year. But we think most people are probably going to do it on a month-to-month basis just simply because affording insurance has been the problem and the subsidies are going to make it easier. The one thing I will add on is that the subsidies have to be reconciled with your income when you file your taxes the next year. So if you say you're going to make $40,000 and you get a subsidy based on $40,000, you end up making $50,000 and you don't call to kind of correct that middle of the year when you figure that out, you're going to actually owe back some money at the end of the year because you got more of a subsidy than you should have gotten. And it works the other way as well. If your income went down and you're getting too little of the subsidy, you would get a bigger refund or a bigger credit at the end of the year. So, sure. Sure.
You talked about subsidies and how people would have an option to either pay it up front immediately or wait till the end of the year.
Yeah.
Is there a way to regulate to make sure that they would use those monies for their subsidies rather than maybe go out and buy them?
Well, the subsidy actually doesn't go through the family. Doesn't go through the individual. The subsidy goes from the Treasury Department directly to the private insurance company. So it doesn't go through the family at all. So in that case, it kind of eliminates that potential for abuse that you have there. The check, the family writes a check, and the Treasury writes a check, but the Treasury check goes directly to the insurance company. So there's a question right here, I think. Yes, ma'am? Sure. So the open enrollment period now is between now and March 31st, and that's for 2014. If you wanted the same kind of Obamacare insurance in 2015, you would need to sign up again, as I mentioned, between October 15th and December 7th of 2014 would be the open enrollment period for 2015. So it's sort of like if you work for a company. Most companies have an open enrollment period where you go and you sit down with your HR person, they give you the packet of the smiling, happy, insured people, and you sign up for that insurance. So that's basically what it's going to be. Every fall, there's going to be a new open enrollment period. You can change plans, at that time, or drop it entirely. You could even drop it in the middle of the year. Let's say you have the Obamacare insurance, and then you get a job that provides you with insurance. You can cut that off and then start your employer-based insurance that next month. Or if you lose that job 2 months later, you can go right back on to being on Obamacare. There's no waiting periods. There's nothing like that. You can just start it or stop it if you have one of those life changes. But if you don't have a life change, like a job loss or a birth or a marriage or something like that, then you sign up during the open enrollment periods every fall. Yeah. Sir?
Just another question. You talked about how the ideal of this new healthcare system is basically to shift away from specialties and more towards primary care as well as VAs. Is there any talk about concern of the quality of care being decreased since essentially your schooling and your specialties are being decreased because of the particular field?
The question was, with the additional emphasis on primary care, is there some concern that we could be losing quality in the specialty care that's being delivered across the country? Surgeons, dermatologists, people like that. Well, I don't think there's going to be any less investment in those fields because they actually kind of pay for themselves. What it is going to be more government investment in primary care. Not that they're going to be taking away from specialty care and delivering that to primary care. They're just going to be adding more investment into primary care through loan reimbursement programs for people going into it, more community health clinics that are being founded, trying to expand medical school classes to bring in people who are going to say, I'm going to go into primary care, from the very beginning. Whole medical schools devoted to primary care kind of specialties. So I think it's more of an addition than it is a subtraction and an addition. for that. I think specialty care are always going to be an essential part. And in fact, a lot of specialists kind of grumble a little bit about the Affordable Care Act, at least the ones I talk to. But what's interesting is that uninsured patients could generally afford going to see someone like my wife, who's a primary care doctor. She might charge them $200 to get a splint, or a couple $1,000s to deliver their baby. And usually people can afford that. If you save up, you can do that. Someone needs brain surgery, chances are they don't have enough money in their bank account to go self-pay brain surgery that a brain surgeon would deliver. So if more people are insured, that means there's more people who actually are going to be able to go and get brain surgery. So you think that there'd be more customers, more insured customers for those specialists than there used to be. So in some cases, I think specialists are going to see more paying and reimbursed customers as opposed to more of the charity care that they give in addition to the paying customers that they also work with. Follow up? Yeah?
Sorry, I'm going to keep going. But I guess my concern with that is,
Yeah.
in your opinion,
Mhm.
is even though you're increasing the amount of, let's say, operations that you're doing, you're decreasing the amount that you're getting paid for that operation. So do you think it'll turn into kind of a wham bam clean demand type of an operation, that they're just going to crank out as many as they can as fast as they can without having the quality of care present?
Yeah, that's kind of the question was, are the reimbursements going to come down for specialty care to make it, more of like an assembly line type of operations, and so specialists are just going to try to get in as many people as they can and not worry about the quality as much. That really depends on the incentives or disincentives of the reimbursements. If you start seeing, and I don't think we've seen this yet, reimbursements for brain surgeries or other kind of surgeries starting to come down, then yes, I think that could be a challenge. That all of a sudden specialists are not going to be compensated as well. It's going to impact their bottom line, and so they're going to have to think of something else to do, more patients, less quality, sort of bending the curve that way. So I don't know. To be honest, I guess you have to follow where the money goes. Medicine works by incentives and disincentives. If you have a $50 copay, you're not going to run to your doctor because you got a nosebleed. If it was a $2 copay or no copay, you might do that. The copay is there as an incentive or a disincentive to get you to do something. And it works for providers as well. They have incentives and disincentives built into their reimbursement rates that they all know pretty well. And so if those are changed to sort of discriminate against specialists, then I think you could see something like that. You could see more people go into boutique medicine, where they don't take any insurance plans, and people pay a $10,000 retainer to be on call for those clients, and everything's cash. And you can see more doctors doing that. You already do see that a lot going on right now. So, yes.
So, how or when are they going to enforce the penalty for not being insured?
Got it. Sure. So the penalty for not being insured for individuals is in effect for 2014. And basically, if you don't have insurance by March 31st, and you don't have insurance, in other words, you haven't purchased the insurance by the end of the open enrollment period, and you remain uninsured for more than 2 months during 2014 beyond that, then you'll be liable for the penalty. So it really kind of goes all the way until May is when that could be. You could be uninsured up until May. Then it'll be assessed on your taxes. So there's going to be some new numbers on your 1040 that say, are you insured? And you say yes, and then you put in your provider number or whatever that is from your insurance company, or your Medicare or Medicaid number, and then you're okay. If you're uninsured, then they're going to be like, okay, well, how much did you make last year? And if you make over 100% of poverty, and you don't fall into some of the other categories of religious exemption, or undocumented immigrant, or a lot of other kind of categories, then that'll be assessed on your taxes. So there'll be that $95 or whatever it is based on your family size. The thing is, when they wrote the law, they didn't put any enforcement into that. So I don't know if I should be saying this, but you don't have to pay it. I mean, it basically will be baked into your taxes, but you could write a check for that lesser amount, and there's no enforcement within the law that they can provide a lien or come after you or anything like that. So, that was one of the ways that they had to get the law through Congress, was not having any enforcement mechanism. But it would be added onto your tax bill. Oh, that's a year. That's a year for 2014, and then it moves up to $325, and I think $695, 2015, 2016, and that's just for an adult, for a single person. It's a little more complicated than just 95. The max is $285 per family. For that, kind of adding it up a la carte, or 1% of your income, which is ever higher. So, yeah.
How does this system compare to other systems for socialists, like Canada's?
Sure.
Because one problem I know with that is there's no socialist medical or healthcare system is
Yeah.
Everybody has coverage, but you're waiting months for a certain period of coverage. So
Mhm.
how does that compare? And do you see us ending up like one of those systems?
Great question. So the question was, do we see the Affordable Care Act, Obamacare, how close is it to a socialized medicine system you might find in Canada or France or Switzerland, Germany, many of the other industrialized countries that have it? I've got a little bit of perspective on that. My wife went to medical school in Quebec at McGill, and medical school there. I lived in Great Britain for a while, so I've sort of seen the national healthcare system. So I can definitely say that the Affordable Care Act is nothing like national healthcare. What it does is, you notice all those people getting insurance on the marketplace, they're not really getting government insurance, they're getting private insurance. It's going to bring several tens of millions of new people into the private insurance market. There will be people joining Medicaid, for sure, sort of new folks coming onto Medicaid, which is government insurance, but the majority of folks are going to go onto private insurance. So in that case, it's kind of pushing us further away from a socialized medicine system in that we have more people joining private insurance markets. They're getting subsidies to do it, but the medical care, the doctors, all that is being delivered through private insurance. So in that case, it's not really moving in the direction of socialized medicine at all. Although some people argue the subsidies are sort of like an end run around that to get people into it. In France, I'm sorry, not in France, in Canada, you do have national health care, where everyone has a national health card and everybody gets a basic level of service. If you work for a company, they can provide extra tiers of health care on top of that. And it really is a provincial system as well. So the healthcare in Ontario, hopefully there aren't too many Canadians here I'd be upsetting. The healthcare in Ontario is actually pretty good, BC, those places. Quebec, where my wife went to medical school, it's super highly regulated, and it's actually, you do have those waiting periods and you do have those lines. And partially is because they say we're only going to have 10 doctors in this neighborhood. And even if there's a need for 20 doctors, the provincial government says, no, we can only have 10. And so that's where the waiting lines get. It's a very highly regulated system. I don't think we'll see something like that happening in America where you have a lot more of a free market, open your clinic, open your doctor's office where you want kind of thing. So in that case, I don't see it approaching socialized medicine. The equivalent in the United States would be single payer, which would be, you probably heard the discussion about single payer versus Obamacare. It came up during the 2010 discussion of what should go into the law. There's some concern that if Obamacare fails, the website doesn't get fixed, there's a lot of shenanigans going on around the cancellations and things. If it goes down in flames, then 10 years from now, what's going to be on the table is going to be single payer, because it's really going to be the only system to bring it back. And actually, if we wanted to address the cost issues and things like that, that I mentioned earlier on, single payer is really the best system to do that. It was the system that would bring our costs down the quickest, in addition to bringing people into coverage. But that's not what Obamacare is. It's private insurance, polyglot system, 5 insurance companies here in Utah, all over in Weaver County, all doing their own thing. So we're not there yet, but I just wanted to mention that you'll probably start hearing single payer mentioned as an alternative if Obamacare falls. Maybe not immediately, but years down the road. So, right here, sir. And then,
I don't know if this just applies in Utah or throughout the whole U.S. Are there health insurance companies that are going to be not under the umbrella of the Obamacare, such as those 6, so that someone could decide, I don't want to pick one of those 6 or however many there are in the Obamacare system in Utah?
Great question. So the question was, are there insurance companies that are going to be offering insurance products outside of the marketplace that we described? Absolutely yes. And in fact, all of the insurance companies in the marketplace are going to be offering plans outside the marketplace as well. Often they're the same plan, or just slightly tweaked, slightly different. But all those, there's going to be a robust private insurance market